Hi guys, let's see about assisted reproductive technology. Assisted reproductive technology refers to any fertility treatment in which the gametes, sperm and ova are manipulated outside the body. Common indications for ART are abnormal fallopian tubes. This includes blocked tubes or surgically removed tubes for PID, endometriosis related infertility, male factor infertility, immunological infertility, and failure of ovulation, as in patients undergone oophorectomy. Investigations before ART. This includes semen analysis, thyroid function test, blood sugar, serum prolactin, serum FSH level on day 2 or day 3, and test for ovarian reserve. Anti-Mullerian hormone is indicated for patients more than 35 years. Ultrasound for viewing the endometrial cavity, serology for chlamydial infection, diagnostic laparoscopy for seeing the tubal patency and to see if there is any adhesions. First, we will see about intrauterine insemination. Intrauterine insemination refers to the procedure by which a sperm is injected directly into the female's uterine cavity, bypassing the cervix. Indications include unexplained infertility, ejaculatory dysfunction, hypospadias, anti-sperm antibody in cervical mucus, mild endometriosis, and discordant HIV status. Procedure. It should be performed around the time of ovulation. It can also be performed along with ovulation induction as an unexplained infertility. Here the semen is first washed as the semen may contain prostaglandins and other antibodies, processed, and motile sperms are concentrated by density gradient techniques. When the ovarian follicle reaches 20 mm on transvaginal ultrasound, injection HCG is given. After 36 hours, half ml of concentrated semen is injected. This is repeated for 3 to 6 cycles. It gives a success rate of 10% per cycle. Donor semen is indicated in azoospermia, immunological factor which is not correctable, genetic diseases in husband, chronic ill health and diseases. Before proceeding with intrauterine insemination with donor semen, appropriate counseling must be provided to the couple. The donor must also be screened for HIV, STDs and also hepatitis B. In vitro fertilization. In vitro in Latin means glass. This literally means fertilization which is happening in a glass. Steps include controlled ovarian hyperstimulation, follicular monitoring and oocyte retrieval, fertilization of oocytes in laboratory, culture of embryos and transfer into the endometrial cavity. Control ovarian hyperstimulation. Here GnRH agonists are given followed by gonadotropin. This gives good quality stimulation and superovulation. GnRH agonist acts by downregulating the endogenous pituitary gonadotropin secretion. This prevents the premature LH surge and enhances the pregnancy rate. It is more important in PCOD. Naferelin and buserelin can be given by intranasal or subcutaneous route. And superovulation can be given by clomiphene citrate or a combination of clomiphene citrate with human menopausal gonadotropin, or human menopausal gonadotropin can be given as such, or clomiphene citrate combined with recombinant FSH. Follicular growth is monitored by transvaginal ultrasound and serum estradiol levels. When 2 or more follicle reaches 17-18 mm, injection HCG is given, following which oocyte retrieval is done after 36 hours after the injection. This is done under the ultrasound guidance through transvaginal route as seen in the image. Semen sample is collected on the same day as oocyte retrieval and it is processed. Around 50,000 to 1 lakh sperm are placed into the culture media containing the retrieved oocyte. About 18 hours later, oocyte is observed for the presence of pronuclei, which is the sign of fertilization. Embryos are cultured for 3 days, after which it is transferred into the uterus 1 cm below the fundus. Not more than 3 embryos should be transferred in a cycle. Vaginal progesterone is given before the implantation to give luteal phase support. Excessive oocyte and embryos can be cryopreserved for the future use. Short-term complications include failure. Oocyte retrieval can cause bleeding. Ovarian hyperstimulation syndrome. It is more common in patients with PCOD undergoing ovulation induction. It is also more common with drugs like gonadotrophins rather than clomiphene citrate. It is seen in luteal phase or in the early pregnancy. The main pathology is the growing follicles will secrete prostaglandins and cytokines, which will increase the vascular permeability. So the extravascular fluid will increase. This is causing hydrothorax and ascites. It is treated with fluid therapy. Ectopic pregnancy and heteropic pregnancy or other complications, multiple pregnancy, and it is costly. Long-term complications include premature ovarian failure, breast cancer, and ovarian cancer. Ovarian cancer is mostly due to the repeated hyperstimulation of the ovaries. Pre-implantation genetic testing, it is done to rule out chromosomal anomalies and genetic diseases. It is more useful for patients with already having a child with a chromosomal anomaly. It is performed by removing a single cell from the embryo and subjecting it to genetic test. Donor ovum is indicated in women with poor egg number, as in elderly women or patients who have undergone bilateral oophorectomy. Here, the donor is first screened for infections like HIV, then they are proceeded with ovulation induction and egg retrieval from the donor, and fertilization happens in vitro with the male partner's sperm and the donor's ovum. Embryo is transferred into the female's patient's uterus. Intracytoplasmic sperm injection. Here, microscopically, one sperm is injected directly into the mature egg prior to intrauterine transfer of the fertilized egg. Indications include sperm count less than 5 million per ml. Here, only one sperm is needed for fertilizing an ovum. So, even can be performed in sperm count less than 5 million per ml. Decreased or absent motility. Previous failed IVF, many abnormal sperms are seen. Sperms are obtained by sperm washing. Testicular sperm aspiration is done in patients with non-obstructive azoospermia, where there is very low sperm production, and percutaneous epididymal sperm aspiration and microsurgical epididymal sperm aspiration are done in obstructive zoospermia. And MESA is more beneficial as large quantity of sample can be collected, which can be cryopreserved for future cycles, and cryopreservation is also useful for young males who are undergoing surgery or radiochemotherapy for their future use. Gamete intrafallopian transfer. Here the sperm is washed and processed. Ovulation induction retrieval is done either laparoscopically or transvaginally. 2 oocytes per tube are mixed with 50,000 sperm, and it is transferred to each ampullary portion via laparoscopy. Here the fertilization happens in vivo in the natural site. The disadvantages of this procedure are both tubes must be patent and it requires laparoscopy, hence invasive. Fertilization cannot be confirmed. Zygote intrafallopian transfer. It involves a laparoscopic transfer of day 1 fertilized egg, which is a zygote, into the fallopian tube. Risk of ectopic is more common in zygote intrafallopian transfer and gamete intrafallopian transfer. Thank you. This is the picture of first IVF in the world in India and in Tamil Nadu.